Hear me? Okay, the boy, that's so much better. Wow. Woohoo. I don't gotta yell. So, welcome everybody to the afternoon session of the AASD. My name is Dr. BEHNKE. I'm professor of medicine in Virginia Tech Carilion. And I'm gonna try to give you a little bit of a taste of the future of diabetes in the next 20 minutes or so. Let's see if my predictions will come true. Perhaps you invite me again in 5 years and you see how many of these predictions have come true. I do have some research grants and I've disclosed them here. And yes, you may take pictures of these slides. They are allowed. Well, you know, we all kind of have a interest in predicting the future, whether it's what's going to happen in the stock market or who's going to win the football championship. And so what I'd like to do is pull out my crystal ball and peer in it a little deeply and see what things we can say about diabetes. And I will make 5 predictions. And these predictions are not always good, but they are hopefully valid. And hopefully you can come back and see these in a couple of years and see if they are true. Here's my first prediction, gazing in my crystal ball. Diabetes prevalence will increase. So when we come together 5 years from now, no matter where you live, in Egypt, in Morocco, in Saudi, in UK, United States, diabetes will be higher. This is a map, and Dr. Schwartz gave a wonderful lecture, IDF. If you don't know, the IDF publishes an atlas. It's one of the great things they do, and you can look at your country and look at the prevalence of diabetes and prediction. And you can see, if you look at the Middle East area, there is a lot of darker color, and the darker color is higher incidences of diabetes. So no matter where you live, diabetes is going to get higher. And of course, most of it is going to be type 2 diabetes. Type 1 diabetes really is quite stable. There was a little bit of a blip during COVID-19. We know very little about the COVID virus in pancreas. We do know that there is COVID in the pancreas and the beta cells, but type 1 diabetes is going to stay the same. But of course, most of diabetes is type 2. And as you can see in this graph, significant increases in terms of a global rate of about 2 or 3% in 2000. By 2040, we're going to have 7 or 8%, and by 2050, 10% of the world's population will have diabetes, and most of that will be type 2 diabetes. So that is my one prediction, and I would say this prediction is unfortunately most likely to come true. Now, hopefully we can prevent it from being as severe, but there will be more patients diagnosed with diabetes. And unfortunately, the disparity of diabetes will expand. So if you go to the IDF website and you look at their diabetes atlas, you can see your country, and of course your countries are in regions. And as you can see, hopefully you can read this, every region, diabetes will increase. In the United States, 24% increase. In South America, 50% increase. But where is diabetes going to increase the most? It's going to be Africa and the Middle East. Almost triple-digit percent increase in Africa and the Middle East, 134% and 87% in the Middle East in the next 20 years. So diabetes is going to increase, especially in the Arabic area. The Arabic and African areas are going to have the highest increase in diabetes. And if you want to look about this, is the current top 10, and you kind of don't want to be in this type 10. This is the number of people, and of course China has a lot of people, so they're number 1 in 2021. Egypt does make the top 10, right below Japan. United States of America is 4, but in terms of the rates, they're quite high. And they predict in 20 years from now, if you still have me in 20 years, I'm not sure, Egypt will actually be even higher on the rate. And a lot of these countries are Arabic countries, you know. So it's going to be there, and it's going to affect Egypt and the Arab countries more. And, why is that? Well, of course, the risk factors are there. We can talk about some of the risk factors. We know that body mass index is a huge risk factor. If you look at patients who are normal, the lower line have the lowest incidence of diabetes, creeping up a little bit, but not that much. Those who are overweight have a higher incidence of diabetes, but if you have a diagnosis of obesity, which is a BMI of greater than 30 kilograms per meter squared, you have up to 20% chance of getting diabetes. So, if they predict that diabetes is going to get higher, and they predict that obesity is a rate, let's look at the rates of obesity. And again, here's your top 20, and you can see Egypt is right there, but a lot of these countries are Arabic countries. UAE, Qatar, Saudi, Jordan, Kuwait. These are countries where obesity is really becoming a big problem. And I really want to applaud the IDF and Professor Sheltut for getting this at the root. This is where the children are, preventing diabetes in children and adolescents. Well, let's get some good news, okay? Let's get some good news. The crystal ball's not all evil and bad. Some complications, I believe, and there's data to support that, will actually decrease. What complications are those? I think the cardiovascular complications will decrease. This is a slide of many countries looking at the rates of lower extremity amputation in per 100,000. And you can see in the past 3 or 4 decades, pretty much wherever country you are, whether a developed or emerging country, you're getting reduced rates of peripheral vascular disease and coronary artery disease, which is good because that translates into mortality. What do most people of type 2 diabetes die of? Coronary artery disease and stroke, right? And actually, if you look at mortality in patients with diabetes, we're actually doing okay. We're getting better. We have a lot of work to do, but in the whole world, and these are just a smattering of countries, you'll see that where people with diabetes, even though they'll have more prevalence, they're going to be living longer. Unfortunately, some other complications won't get better. And this is a slide, and I know my friend Mick Gawenda is going to talk about this in the future, and I don't want to steal his expert opinion here, but if you look at the rates of diabetes-associated end-stage renal disease throughout the last 15 years or so, if you look in countries like United States, which is about the third or fourth bar down, maybe it got a little bit better with SGLT2s, maybe not. If you look at other countries, UK, they have Scottish data, which got a little bit better in 2013. They went up a little bit. But there are other countries like Mexico, like Singapore, like Korea, where actually this is going to get worse. So again, you're going to have a disparity. Countries that have access to things are going to maybe do a little bit better than others. So we really got to work on that. It really should be not an indication of how you get your diabetes cared where you live. There should be a worldwide, and that's why I really support Inez's efforts and also IDS efforts to make diabetes a worldwide issue and begin a worldwide care. Well, if obesity is the major driver for type 2 diabetes in the world, right? We've established that, and especially in the Middle East. What's going to happen? Obesity drugs will dominate. And if you think obesity drugs are all the rage now, this is going to significantly increase. And I'll show you data to support that. This is a look of United States prescriptions for the past 7 or 8 years or so for liraglutide, which is one of the first GLP-1s to be out on the market, Victoza daily, semaglutide, and tirzepatide. And you can see even in the past 3 or 4 years, millions more prescriptions for these drugs. But it's not only the United States that this is going to be a driving force, it's going to be a worldwide thing. So again, looking at the past 5 years, The amount of prescriptions for Ozempic, Rybelsus, and Wegovy, 3 GLP-1s, is skyrocketing logarithmically, and it's not all United States. Previously, it was 99% United States. But look at this graph on the right in terms of the billions of dollars. The second most high market is Europe, the Middle East, and Africa. So these drugs will be coming, if not here already, they'll be coming even more so to the Middle East, Africa, and the Arabic Association area. So these drugs are going to be something that's going to be more and more available. Now, just to give you a little bit of a whetting your appetite, you know, you have the tirzepatide, you have the Ozempic, but there's hundreds of other drugs in the pipeline. There's 75 in phase 2 and 75 already in phase 1. And most of these are GLP, some are GLP plus GIP, some have amylin, some have glucagon. The triple acting agonist is going to be released probably soon. Most of them are parenteral, but more and more of them are becoming oral. So we're going to get, I believe, in the near future, my prediction, you'll be able to have a pill that you can take instead of a weekly shot that will have significant help in obesity. Just really to whet your appetite in terms of these things, biogramimab, which is a monoclonal antibody, its combination with semaglutide, it definitely helps with reducing fat while preserving muscle mass. And one of the problems with GLP-1 is something called treatment-induced sarcopenia. Yeah, you lose muscle, but you lose fat, but you lose muscle. So people are more prone to falls, they're more prone to be weak and things like that. This new combination is supposed to preserve the fat lowering, but also not irritate the muscle loss. Amylin has actually been around for a while. I'm not sure if any of you have used it. I used to use it 10 years ago. It's coming back. Alonidide is going to be an amylin receptor agonist. And there are some small GLP-1s in clinical trials that will be used as oral treatment. In 26, again, there's going to be an oral GLP-1 from another company. There's going to be more use of combination products, especially glucagon is going to make it to the market. And amylin is going to be combined with GLP-1 and other medicines as well. So, 15-fold increase in diabetes drugs, and the food and beverage companies are going to have to adjust. The food and beverage companies in America are actually having a problem with their profits because with all the Ozempic and the Wegovy that we're taking in America, they're not selling as many soft drinks and high-carb meals. So this is going to be something there. The final prediction I want to make, and I want to also encourage you, after this session is over, to come to the diabetes workshop in Hall C later on this afternoon, because diabetes management will be technology driven. And if you are not familiar with technology, if you're not very comfortable with technology, it's going to leave you behind in many areas. When Banting and Best, Carlip and McLeod discovered insulin in 1922, the first patient was given it, Robert Thompson. You had one insulin was 1 cc of unpurified pork pancreas, and it was unspeakably wonderful. Of course, Robert Thompson died a few years later of complications of diabetes. Now we have situations where your young child can have a continuous glucose monitor and an insulin pump device. The glucose monitor will check the blood sugar, will give the data to the insulin pump device. The insulin pump device will give you the insulin you need, and this child and their family can sleep peacefully with a hemoglobin A1C in the 6 range without hypoglycemia. But you got to know the technology, because this is really all technology driven. In the United States, if you look at the amount of insulin pumps that are out there, in the last 5 years, over 60% of patients with type 1 diabetes are using insulin pumps, and it's probably even going to be more. So you really, if you're taking care of patients with type 1 diabetes, you're going to really have to know insulin pump devices, and that's technology. These devices are great. This is a study done in my clinic, and it didn't come out that good, but you can see, hopefully, over on the right hand, this is going to work. Let me see if this pointer works. Okay. There we go. Yeah, there we go. Good, maybe. All right. So this is a group of patients that we see. So what I do in my office, I see only poorly controlled type 2 diabetes and type 1 diabetes. You have to have an A1C of at least of 9 to come to see me. And some of these are 10, 11, 12, 13, 14, 15. So the average A1C is about 11. And to put all these patients, some of them had substance abuse history. Many of them had mental health issues. In the hospital every month with diabetic ketoacidosis. Put them all on a closed loop pump system, and all of them had A1Cs of less than 9, and most of them had A1Cs in the 7 range. Without hypoglycemia, without going to the hospital for DKA. So I mean, these technology things are really great, but you got to know how to use them, and you got to use, be with that. All right. The last thing is you're going to see a lot of apps, and these are apps, whether they are CGM apps or service provider apps, education apps. Dr. Sheltut did a nice presentation about the app that she's promoting for prevention of diabetes, online community apps, coaching apps. You're going to see a lot of these apps, and if you're not able to really dive into that, it's going to be hard. If you look at the global marketing of health apps for the last 8 years and prediction, you're going to see a huge increase in the amount of app use, and it's not all North America. North America is going to be just a portion of it. The majority of healthcare apps is going to be in non-North America and Europe, and this makes sense. Because you have someone in rural communities. It's hard to get to the doctor, but most communities do have a smartphone, at least some kind of connection. And if you can have that connection to your people there, it's great. We've done a great job in the United States looking at remote monitoring and healthcare apps. So this is something that we're going to have to get to know. Wearable sensor data, you get this all together, you get some artificial intelligence, and then you get some deep learning, where the app starts learning the patterns and is able to predict, and you can get an outcome like our previous young lady, who rests quietly. Well, I am almost done with my fortune-telling session, so I want to leave you with hopefully a good feeling about the things that are happening in the future. Knowing what to predict and how to treat it is good. And I'm really excited to hear the next speaker, who's going to talk about a subject that's dear to my heart, diabetes management in emerging countries. Thank you.